Good morning, everyone. It's lovely to be here. Let me say a big thank you to the organizing committee for having me as a keynote speaker this year. And lots of congratulations indeed on an excellent organization of what seems to be a very lively scientific event this year. Cosmetic lengthening, that is the application of distraction osteogenesis for the purposes of height increase in otherwise physically healthy individuals, is a bit like the elephant in the room. Everybody, doctors and the public out there, knows more and more about this treatment. It is regularly discussed in dedicated sessions in the most orthopedic meetings, domestic, like the British Hip Reconstruction Society meeting every year. It was also discussed in last year's World Congress of ASAMI and International Hip Reconstruction Societies in Beijing. It is performed with increasing trend, but it is still a bit of a controversial treatment, mostly because many people are still unfamiliar with this. Let me say here that even seasoned hip reconstruction surgeons do not routinely deal with lengthenings of 8 or 9 centimeters in both femurs or both tibials. The patients also have their own needs, and this unfamiliarity increases the reservation or the fear sometimes about this treatment. Today, we will be discussing about the efficacy and the safety of this treatment under the prism of medical ethics, hopefully to make you feel a bit more familiar and comfortable with this treatment. As we all know, the 4 fundamental principles of medical ethics are beneficence, that is, the doctor's duty to actually provide a benefit to the patient, treat their condition, or improve their suffering, their symptoms. Non-maleficence, that is the doctor's obligation to weigh and judge the related risks and comorbidities and burden of the treatment itself against the benefits, and make sure that it's not an unnecessarily burdensome or risky treatment. Autonomy, which is the doctor's obligation to respect the patient's preferences and priorities in relation to the treatment and provide them with adequate information in order to help them make the best decisions for themselves. And finally, justice, which is the moral obligation of the doctor who provides the treatment to provide all necessary resources and means for the recovery of the patient. The first 2 principles originate directly from Hippocrates, the father of medicine, who said in ancient Greek, "Ophelei e mi vlaptin," which means to help or at least do no harm. Let me say that Hippocrates lived and worked for many years and eventually died in my birthplace, the city of Larissa in central Greece, and there is a magnificent tomb there to honor his memory. So I invite you to visit it when you have the opportunity. Autonomy and justice were introduced much later, around the 18th century, and this is when we start discussing and considering these principles. Let's see them one by one and see how they apply in cosmetic lengthening. What do we actually improve? Is it the soft stature? Is it the psychological symptoms of anxiety and sadness related to someone not being as tall as they would like? Do we improve their chances of success in life, professionally and personally? All of this, none of this? Well, in last year's World Congress in Beijing, I shared data from 140 patients with a follow-up of more than 2 years, and I'm going to be sharing some of this data with you today. In these patients, the average achieved lengthening goal in the femur was around 7.5 millimeters or 3 inches in the femur. In the tibia, it was around 5 centimeters or 2 inches. Quite reliably and quite realistically. I mean, more than the majority of the patients can reach lengthening goals of 8.5 in the femur or 5.5 centimeters in the tibia if they want to. And the other ones can reach at least 90% of their goal. So if I draw your attention to the percentiles chart on the right, which actually comes from the Unsure anthropometric study from 2012 from the United States, with a huge sample population of more than 6,000 healthy men and women, we can see, for example, that a man who starts from a starting height of 1.67 meters on the 10th percentile, if they lengthen 14 centimeters, lengthening their femurs and tibias, they can move up to a height of 1.81 meters of height on the 8th percentile. This means that before surgery, 90% of people around them were taller than them, and after surgery, they are taller. The patients themselves are taller than 80% of people around them. Similarly, a person who starts from a starting height, I'm talking about the blue example, from the 20th percentile, 1.7 meters of height, lengthening their femurs by, let's say, 8 centimeters, they can move up to a height of 1.78 meters of stature on the 65th percentile. This means that before surgery, 80% of people around them were taller, and after surgery, they are themselves taller than 65% of the people around them. And you can imagine how big a change of perspective this must be for these patients. So we can certainly say that we do improve height quite significantly. True height increase. I put this slide here just to give you a first flavor about these patients, because they are not like the other orthopedic patients who suffer from physical problems. So these patients are usually young, well-educated, with lots of information from the internet. At the same time, they are confused about what is important and what is not, and they don't know how to prioritize the information. And at the same time, they have a very persisting attention. Sometimes it can become an obsessive attention to details. So the question is the question comes because they know, they understand that the anatomical axis of the femur, along which we lengthen, comes at an angle of 5 to 7 degrees with the vertical axis of the body. So the question is how much they actually increase their height by lengthening their femur along the anatomical axis by, let's say, 8 centimeters. That's an easy answer to give based on trigonometry, because there is a right triangle that is formed between the anatomical axis and the vertical axis, and just by applying the Pythagorean theorem formula, we can say that for a lengthening of 8 millimeters in the femur, the height increase is 79.4, and for 90 millimeters of lengthening in the femur, which we can do with the Guichet nail, the height increase is 89.3 millimeters. So it's really less than 1 millimeter, really non-clinically significant for us, but it is for the patients, for these patients. And this is why I routinely lengthen 2 millimeters above the agreed lengthening goal in order to accommodate and account for trigonometry, and the other millimeter in order to accommodate for the margin of error of the measurements of lengthenings, which is, despite all these decom files and softwares with digital rulers and magnification, the range of error is within 1 millimeter. In order to discuss about any beneficence on psychological symptoms, we need to understand a bit more about the condition of body dysmorphic disorder. It's a condition which belongs to the obsessive compulsive disorder neurosis family. The main feature is a persistent preoccupation about a perceived or real physical flaw in the body. It can be the nose, it can be the height. It appears with a spectral severity. It can be just an uneasiness about the height, or a more persistent preoccupation or mental fixation affecting their daily life, their work, their professional or personal relationships. And it can escalate to more severe cases of delusions or psychotic symptoms or self-destructive behavior. The prevalence of body dysmorphic disorder is around 0.5 to 4% in various studies. We don't know exactly how much this is about height dysphoria. Height dysphoria is a term that we use to describe the unhappiness about height. In this patient series, sorry, before I go there, let me tell you things about the COPS, Cosmetic Procedure Scale Questionnaire. This score was developed in 2012 in the UK, aiming to be used as an instrument for screening and diagnosis of body dysmorphic disorder, but also as a tool of evaluation of any response to treatment. It consists of 9 questions, which are answered by the patient. It's a self-reported score, and the answers are rated from 0 to 8. So with a maximum score of 72, 40 is the threshold above which body dysmorphic disorder is considered likely, and the patient should be referred for further assessment. So with that in mind, the patients in the series that we analyzed had a preoperative average TOPS score of 28.5, and at the final follow-up, more than 2 years later, 11.2. So there was a considerable improvement, a significant improvement in how they felt about their height. We don't really know if we actually help them improve their chances of success in their professional or personal life or in their career. We do know that cross-culturally taller people are related statistically with better pays or better careers or better chances of finding a person to develop a personal relation with. But we don't know how our patients really perform after this surgery. Non-maleficence is the second principle to weigh the benefits against the risk and the burden of the condition. In the context of cosmetic lengthening, maleficence is related to the surgical complications themselves, the pain, any long-term functional limitations, or any risk of future osteoarthritis. With regard to the surgical complications, I'd say that this surgery carries the same risks as any other major orthopedic surgery, like bilateral osteotomy of the tibias or femurs and intramedullary nailing with ringing. Actually, because these patients, nearly all of them are young and fit and not obese, with no other pre-existing comorbidities, with intact soft tissue envelope. Actually, they stand on the safer end of the spectrum of possibilities for complications. But at the same time, because exactly they are physically healthy, they are less tolerant to problems, difficulties, or complications. I'd say that bone infection is very rare. I have never had any serious deep bone infection so far, not only in these cases that I'm presenting. Thromboembolism and thrombosis is a known risk with any orthopedic surgery in the lower limbs or pelvis. It's around 1 to 2%. In the recent years, since after the COVID pandemic, there is a relation between history of recent COVID infection and the increase of thrombotic incidence. So now we give blood thinners for longer, like for the whole lengthening period. There is a 4% chance of blood transfusion with femoral lengthening. It's less with tibia. Delayed union or non-union, again, because there is a healthy soft tissue envelope and these patients are non-smokers, otherwise they are excluded from this treatment. The possibility of non-union is really low. So far, I have had 1 case of tibia non-union which required bone grafting. Delayed union, it's around 5 to 6%. At least this is the percentage where I decide to go slower with lengthening or take a pause with lengthening in order to allow bone consolidation to progress. Postoperative deformity, not easily accepted by the patient. This is a case of bilateral tibial valgus deformity, which came to me for a second opinion, and I treated it with revision of nailing with the application of blocking screws. And I think that any surgeon who undertakes lip reconstruction, and especially cosmetic lip lengthening, should be familiar with the use of blocking screws in order to minimize as much as possible the possibility of postoperative deformities. Mechanical failure of implants, bending or breaking. We have two implants that we use, 2 intramedullary nails, the precise and the G nail or guichet nail. The rate in various studies with precise is around 5%, with Gmail, we're preparing a study now. We have reviewed more than 1,000 cases in the last 25 years, and the rate is around 1.8% only. Pain, limb lengthening is not that painful, despite what many patients believe, or even doctors. I'd say it's about the duration of the pain for the whole lengthening period and not the intensity itself. So having a daily ache or soreness during some parts of the day, let's say after physiotherapy, for example, can be mentally challenging or tiring if you're not prepared for this. But the intensity of the pain is not that high. I have seen that more than 50% of my patients take less painkillers than what I prescribe them. One issue that we had to deal with was when we introduced the G-nail, the cushion nail. This is sorry. Oh, the video is not playing. Anyway, in this image, it shows the patient, you can see, which needs to lay down and grab their leg and rotate it inwards and outwards in order to activate the ratcheting mechanism and lengthen the nail. And this, although it's a totally safe maneuver, and it's a maneuver that we teach the patients how to do again and again until they become independent with it, it can be stressful. It can be scary for some patients. And thus, it can feel a bit more painful. And we, in this case series, there was approximately 8% of patients which just couldn't do it. The solution was to do a manipulation under anesthesia. So, which is a quick procedure, takes like less than 5 minutes under light sedation and muscle relaxation. It's done in the hospital by me or by a member of my team. And this seems to solve the problem for the remaining lengthening period. I mean, so far we didn't need to do a second MUA for the same patient. Is there any impairment in the physical function after this surgery? In my practice, I use the Disability Rate Index score, DRI score. It's the score that we used quite often when I was working at Oxford University Hospital. It belongs to the PROMS type of scores, patient-reported outcome measurement scores. It was developed by SAR in 1994. It consists of 12 questions about activities of daily living, which are scored in a visual analog scale type across a line. And the score is calculated as a percentage of impairment from the normal function. You can see on this table from the original paper that healthy persons score around 0.8, healthy persons with minor ailments 8.7, indicatively neck and shoulder problems score around 27, and knee arthritis scores around 15. So with that in mind, you can have an understanding about these patients of mine. Preoperatively, the DRI score was an average of 7.28. At first year follow-up, 12.46, and at the final follow-up, more than 2 years after the surgery, 11.9. So there is a minor diminution of their function, and the patient should be informed about this preoperatively, but they generally remain close to the region of healthy persons with minor ailments. It was a bit of a surprise to me to see that preoperatively the average score was 7.28, because these patients, all of them, are physically healthy, young, active, fit people. My only explanation is that it's either because of language barrier when they come for a non-English speaking country, or because of the body dysmorphic disorder itself, which affects the way they perceive the function of their body. Risk of arthritis, we all know that arthritis is multifactorial in its etiology, genetics, hormonal environment, lifestyle, body weight. When it comes to postoperative arthritis, it's related to deviation of the mechanical axis. Mechanical axis, let me remind you, is the line which connects the center of the hip joint with the center of the ankle joint and represents the direction from where the body weight is transferred to the joints and then down to earth. I'm a knee surgeon, that's my other specialty, so I learned to think with Mikulic's line. As long as the mechanical axis remain between 40 and 60% of the Mikulic's line, then the knee is balanced, and the knee and the possibility for arthritis is minimized. Deviation of axis can occur in the context of fluid lengthening either as a result of the surgery itself, as I showed you earlier, or via progressive mechanical failure, that is bending of the nail. As you can see on the right, it's a case with bilateral femoral precise nails. It's bent and created a vallus deformity in the femur, and I had to treat it. I explained to the patient the risk of future arthritis, and we revised it with simple fracture nails in order to correct the deformity. Autonomy. Cosmetic surgery in general, of any specialty, is a challenge when it comes to autonomy and informed consent in patient selection. Because body dysmorphic disorder itself can be a self-destructive behavior or can limit the patient's ability to comprehend risks and limitations of treatment. So this sometimes can make the informed consent that the patient gives questionable or not valid. This is a case of a patient who lengthened his tibia 8 centimeters against my advice after he left Athens, only to develop this very severe equinus deformity, or ballerina foot, as these patients call it. And he had to come back, and I did a gastric recession in order to improve the condition. Body dysmorphic disorder can present in a by proxy variation. Very rare. I had one such case where a young girl in her mid-20s came with her mother in my office to discuss the stature increase, only for me to realize through the consultation that it was actually the mother who was unhappy and depressed with her daughter's short height, and the daughter, the girl herself, was very comfortable, and she was just about to do it for her mother. And of course, I discharged them. I advised them to visit both a psychologist. In addition to the vulnerability and the challenges that these patients have, there is also sometimes an aggressive marketing, online promotion, influencers who try to educate, presumably patients, but in reality to direct them to treatments, and this can increase the confusion and how can I say, it can affect the expectations of the patient. Obviously, a robust informed consent process needs to be in place in every practice that performs cosmetic lengthening. In this country, in the UK, there are robust guidelines from the General Medical Council and from the Royal College of Surgeons, which mandate that every physician who undertakes cosmetic procedures of any kind should consider body dysmorphic disorder, assess for it, and be prepared to defer the surgery and to defer the patient for psychological support if needed. I implement in my practice as protocol of patient selection at least 2 consultations. I do COPS questionnaire, and I also use some red flag questions that I have came to understand by anecdotal experience, trying to understand, to identify which patients will probably not benefit from this treatment or are not in a position to understand the limitations or to appreciate the outcome. And with this protocol, approximately 6% of my candidates are excluded from this treatment. I evaluate this protocol with a very good question. If you knew back then what you know now about this treatment, would you still decide to do it? I ask this question at the final follow-up. A staggering 94% says yes, probably or definitely yes. There is a 6% who says probably not. I find it encouraging that 0% says definitely not. I would like to find a way to identify this 6% who are not so happy with the decision they made earlier. I recently introduced what I call the expectations question, which you can see it on the table below. I'm trying to understand to evaluate my informed consent process by seeing if I make it look too nice or too bad. So the question is, remember what you thought before surgery, but how difficult or easy this treatment is going to be. Would you now say it was much more difficult, slightly more difficult, about the same, slightly better, or significantly easier? I don't have data because I only recently introduced this question. Justice, the fourth but not least principle: adequate resources must be offered to the patient for the recovery. These are two cases of medical negligence of other offenders. On the right, the surgeon knowingly used a smaller size implant just because the larger size implant was not available at that point. In a patient who was overweight and had big enough bones to accept the bigger, stronger, safer implant. The other case on the bottom left is a case of a surgeon from the United States who decided to undertake the nail removal of G-nail, despite the fact that this G-nail is not available in the US. So there was zero familiarity with the implant. And in addition to that, he attempted to do that with universal extractors, not the specific instrumentation of the nail, only to break and dismantle the nail, and thus having to resort to a bigger surgery with a knee approach in order to remove the broken part of the nail. I'd say that honesty should be the fifth principle of medical ethics, because without honesty, none of the other principles can be applied. These patients need intensive physiotherapy. I have found very useful the anti-gravity treadmill in order to preserve muscle coordination, muscle memory, and proprioception during the lengthening period, especially when we use precise nail, which is a non-weight bearing implant. Doctor needs to be able to make himself available as needed, frequent follow-ups. In Athens, because we have many patients who come and stay there for 2 or 3 months of the recovery, we have gone as far as having our own dedicated driver to transfer the patients, and a Chinese guest house with catering of Chinese food in order to make the whole experience for our Chinese patients a bit more comfortable. Obviously, it becomes clear that more information is needed, and this is what I highlighted in last year's World Congress of International Reconstruction Societies in Beijing. I think it's my generation's duty, now that cosmetic lip lengthening becomes more and more widely known and performed, to standardize the protocols of diagnosis and treatment worldwide, and to find a consensus about what data we need to collect in order to be able to compare outcomes and hopefully some years later have some good quality meta-analysis. So it was with great pleasure when I was informed that Aalborg University in Denmark, a very renowned orthopedic university and center there, initiated the RECON study. It's a Delphi survey study, aiming at this initial stage to identify which parameters are considered important in limb lengthening by the patient themselves, their carers, and the treating teams. My clinic became a national hub for recruitment in Greece and in this country, and we're recruiting. In next year's World Congress in Kuala Lumpur, we will be discussing the first results and the next steps. So I think stay tuned for more information, and great times ahead into making limb lengthening a safer and better treatment for everyone, everywhere. Thank you.